Welcome to Dr. Ziegler Weighs In. I'm Zachary Ziegler, professor of exercise physiology and fellow of the American College of Sports Medicine. I've authored 2 books on weight loss and published dozens of research articles. I'm here to cut through the noise and give you evidence-based insights you can actually use. Now let's dive into the science. Welcome to episode 1. Thank you for taking time out of your day and listening, and I hope it can be beneficial to you. I think that it can. Let me just start this podcast series out by talking a little about the why. Historically, if you've wanted to keep people down and out, you kind of keep them ignorant. You don't give them an opportunity to learn, to educate themselves on different things, and then you can kind of tell them whatever you want. We live at an interesting point of time in history where we have so much information at our fingertips. But too often, people with just a little bit of information become really dumb, meaning they can't decipher between fact and fiction. When we look at the world of weight loss, which is going to be the main focus of this podcast, we'll talk about exercise and metabolism and things like that, but really it's going to be weight loss. When we look at the world of weight loss, there are so many myths, fads, things out there that people ascribe to science or having some sort of backing. I think the biggest example of this issue of you learn enough to where you think you know everything, and that makes a problem. I think the basic example of this was during the COVID pandemic. Not that we're going to get into the issues of the pandemic, but if I was to ask rhetorically to the listeners out there, what are your thoughts on wearing a mask? Should you wear it? When should you wear it? Should you double mask, right? That became a thing for a while. On the vaccine, is it going to stop you from getting COVID, spreading COVID? Is it going to stop you from getting severe COVID? Is it going to increase risk for different side effects? If I was to ask this question, I undoubtedly would get a lot of different answers. And then I'd say, well, where did you get that information that you based this idea on? And hopefully many of you would say, well, something about the science. Maybe the news was showing you the science, or you think the science says, but yet we all believe differently about those things. And so the purpose of this podcast is going to say, okay, what does the science truly say about these topics in relation to weight loss? And we're going to try to delve into that to where we can make evidence-based decisions. The way we're going to set this up is we're going to have weekly podcasts, and we're going to start each one out by a news brief. Every week, maybe not every week, but every few weeks, science is put out there into the world that we have at our fingertips. What does that science say? And so I collect that every week. I subscribe to all the different journals out there in relation to obesity, and I always read those. And so I'm going to select, almost like we would with news. If you're going to tune into the news, you want to hear what's going on, I'm going to select one or two of those studies and just take a minute or two and go over kind of what that study says to keep you kind of updated on the information. And so that's only going to take a few minutes on each of these weekly episodes. Then after that, what's going to happen is we'll have episodes that cover, or multiple episodes that cover a topic in relation to weight loss. For example, what we're going to start today is a 3-part mini-series on they're called GLP-1s, or that's the Semaglutide, Ozempic, Wegovy, Trizepatide, all of that category of drugs that are really hot right now in the weight loss field. So that's going to be the first 3 episodes, which I'll drop, by the way, all at the same time. And so hopefully you enjoy, you can keep listening. And then after that, we'll move on to different topics. And I would love to get feedback as well if there's anything you want to cover. Hopefully it's beneficial. So let's get started. Let's get started with our weekly news update. I just selected one study from the current obesity reports. This just came out, and I think it's pertinent because this study wanted to ask the question of what is the ideal diet to favorably alter muscle mass and fat mass. And tons of studies have been done on this. The difference, though, in all the past research that's already been done on this was looking at BMI. Those of you listening are aware BMI is not perfect, right? It doesn't tell you muscle mass or fat mass. And so this particular paper was a review paper that said, okay, let's look at the impact of different diets specifically on fat mass and fat-free mass. And here's what they found. And so I'm going to read from their discussion. This was a review article, and it said that high-protein diets and ketogenic diets, ketogenic diet essentially a no-carb diet, showed the most effect, showed superior in maintaining lean body mass during a diet. One of the issues about dieting is almost always you're going to lose lean mass, muscle and bone. We're going to get into semaglutide. That's one of the biggest issues. But high protein diets, a ketogenic diet, which usually is also a high protein diet, is pretty good at maintaining muscle mass. Interestingly, though, the issue with those diets that they're finding, which we've seen, is they're really hard to stick to. You know, I've never met somebody who's been like, you know what, I haven't eaten bread for 5 years. That just doesn't exist. And so you'll hear me say this a lot when we talk about the best of something, the best exercise program, the best diet. It's usually just going to be the one you stick to. Yeah, we can delve into the details, but really the one that you stick to, if you can't stick to it, it doesn't matter how good it is. So anyways, so that was the take home of this paper. They did find that intermittent fasting or time restricted feeding, very good for improving metabolic health, meaning they found it was really good to improve insulin and diabetes type outcomes as well. And so that's the one I wanted to share with you today. And we'll add more of the recent news coming out. So let's get into semaglutide. So I want to start. Let me get things situated here. I want to start by talking about somebody named Kelvin Kiptum. I don't know if anybody here has heard of Kelvin Kiptum. Kelvin Kiptum ran the Chicago Marathon in 2 hours and 35 seconds. He holds the world record. Now I'm going to pose a rhetorical question. Those of you out there, do any of you think you could run a marathon in 2 hours and 35 seconds? I'm going to assume most probably said no, but let me kind of keep digging at you a little bit. What if I gave you the best training available? I gave you the best personal trainers, the best physical therapists, the best medical team, the best nutritional advice. I gave you the best of everything, the best that you could get. Do you think you could train to the point to where you could run a marathon in 2 hours and 2 hours flat and 35 seconds? That's the record. Now, if you're saying yes, that you think you can, I hate to burst your bubble. I promise you, I would bet money you cannot do it. 2 hours and 35 seconds. I should have done the math. I think that's like a little over 4.5 minute mile, something like that. Every single mile. It's crazy. So why am I saying that? Well, Kelvin Kiptum, who did have the best train, well, I don't know his training schedule, but I'm going to make the assumption, trained really hard, had great people around him, his team, to help him to do something like this. Also had God-given genetics that allowed him to do that. I start this discussion. This is our episode 1 on semaglutide. Okay, giving the background here, and we'll get into episode 2 and 3 later. I start that with this because there is a contrary that must be proved in the world of weight loss. Too often, we say, well, weight loss is only willpower. And I am Mr. Pick yourself up by the bootstraps. You can do it. Go achieve it. Work hard. That is in my DNA. But you can't ignore the role of genetics when we talk about things like weight loss. Future episodes, we're going to talk about how big genetics play. But right now I introduce this because I'm going to this world record holding marathon runner to say that even with the greatest willpower that those listening to this podcast have, they would never be able to achieve what he achieved because of genetics. So we cannot diminish that. When we say, well, what contributes to obesity, you could kind of picture in your mind kind of 3 circles and they overlap in the middle. And each circle is highlighting what contributes to obesity. We have environmental factors. Things in the environment definitely contribute. We call this the obesogenic environment, where maybe it's something where the neighborhood's not built in a manner that promotes, walking and physical activity. Maybe it's fast food on every corner, things like that. That's the environmental factors. Then we have what we usually talk about is the behavioral factors, and obviously that plays a huge role. But then the circle that, at least in traditional diets and personal training field, we kind of ignore, and that is the biology, the genetics, the physiology. And the reason I'm saying this is these drugs, and we're going to get into specifically what they do. If they can help, I'm not saying they alter genetics at all, but if they can help deal with some of that biological factor that impedes the ability for someone to lose weight, I don't know if that's a bad thing. And so, because when I teach, most of my students tend to be, they're exercise science students. They tend to be, they work out really hard and they're probably fit. So they don't understand why, well, if I'm working out and I'm lean, even though genetics probably made them that way, why can't everybody be? Well, we can't overlook the genetics here. And so with that in background, let's kind of talk about what brought us to the point of where we are with these medications. Again, the medications, Ozempic, Semaglutide, Wegovy, that's the category of medications we're talking about, GLP-1s. Well, we know that about 42% of Americans are obese. And if we actually delved into specific subgroups, for example, African American women, it gets upwards to 55%. And so that 42% is just average. And I would ask you rhetorically, why? Meaning, it's not as if we haven't been trying, right? I mean, in the 80s is when the obesity epidemic really took off, and we've been trying since then, and we've been failing. And so maybe we should look at a different way to treat this epidemic. But one of the problems with us continuing to get a bigger waistline is, in a lot of circles, thinness is still idealized. Often I would look at Barbie with my students, and I would say, okay, let's look at Barbie, which we give our little girls, right, Barbie to play with, and say, well, let's look at the dimensions between Barbie's neck, bust, waist, and hips, and the ability to find a true female that fits that is almost impossible. If we look at Miss America, I'm talking about Miss America contestants. If we say, well, what was Miss America supposed to be? Well, Miss America, and people joke about what it is, but what it's supposed to be is the ideal American woman, right? It's supposed to be this beautiful woman. She has talents. She's educated. That's what it's supposed to be. So if we take that, we say, well, let's look at average BMIs of Miss America over time. Once we get into the early 2000s, almost all Miss America contestants have a BMI under 18.5, which the World Health Organization says is undernourished or underweight. At the same time, the average American woman's BMI is about 25.5, 26 at that same time point, which is in the overweight category. So this creates psychological problems, body image problems, where we're still idealizing leanness, and yet we're getting bigger as a society. And so that creates some issues. Albert Stunkard is really one of the big pioneers in obesity research. Textbooks that are used at universities. He's written dozens and dozens of research articles on many different theories and topics in obesity that we still use today. At the end of his prolific career, and I'm making that point, this is the end of his career when he's seen everything. He made this statement, quote, "Most persons will not stay in treatment for obesity. Of those who stay in treatment, most will not lose weight. And of those who do lose weight, most will regain it." Now, you could hear that and say that that's kind of a pessimistic statement to make. But it's true when you look at the data. When you look at all weight loss data, for some reason it seems that when people go on a weight loss program, whether it's exercise, diet, medication, which we'll get to, it seems that at 6 months, they hit peak weight loss. I don't know why it's 6 months, but every study shows it's 6 months. They hit peak weight loss. After that, the farther removed from that 6 months, so the longer that you follow them, they gradually start to gain weight back. There was a meta-analysis conducted that said, well, how much weight can people actually keep off 4 years later? So at 4 years, how much weight can you keep off? And this is important, by the way, because often people say, well, I just lost weight. I lost, I don't know, pick whatever the weight is. I lost 20 pounds, 30 pounds. And of course I say, well, that's great. You know, they said, and the person will say to me, and I've kept it off. Well, that's awesome. How long have you kept it off? And they'll say something like, well, about a year. Now, I would never say this to them, but the reality is that doesn't count. Don't get me wrong, it counts. They kept it off for a year. But when you look at the data, they've probably gained some back. And the longer you follow them, by the time you go out 4 years, average weight loss is about 3% of starting body weight. So I would ask, is that effective weight loss? If I was to tell you, hey, I'm going to charge you and I'm going to help you lose weight, and in 4 years, I guarantee you will have 3% of your body weight off, would you pay me? I highly doubt it. And actually, when you consider that the average American woman, middle-aged woman, wants to be 32% lower, her body weight, 32% lower than where she is now, which is crazy, then you look at 3 to 4% and you say, well, that obviously is not successful. But the interesting thing is there was another study, meta-analysis, where they said, we're going to take all the research out there and say, what do we know? That said, well, let's look at that 5 years instead of the 4. And what they found is by 5 years, instead of having 3% average weight loss, there was 0. Meaning, in essence, you're not going to keep your weight off. So why? Why can't we do it? And that's important to get into to understand these drugs. It goes back to this genetics. And again, we're going to have episodes specifically about genetics. I'm going to talk about one study, maybe two, that I think is really important, though, to introduce to this topic of these weight loss medications. The first one was a classic paper done by Albert Stunkard, the same individual I read that quote from. And it was an identical twin study. These are the best studies to determine the role of genetics in weight loss. And what he did is he went to adoption agencies. And he went to these adoption agencies, to these mothers who wanted to give their babies up for adoption. But he wanted moms who had twins. And he wanted moms that had, different moms that had either monozygotic or dizygotic twins. So identical, non-identical twins. And he followed them all. So he got there at this adoption agency when these mothers were giving their twins up for adoption. Now, those individuals who were adopting the babies, sometimes they were not in a situation to take both of the babies, so they might take one. This scenario is the best way to determine the roles of genetics. So what this means is, if you are a mother that is pregnant with identical twins, you give your twins up for adoption, and one person adopting one baby takes that baby, adopts that baby, and raises that child in a specific environment. And then someone else adopts that baby's twin and raises that child in a completely different environment. This is the way you determine the role of genetics on something. And so that's what Albert Stunkard did. The average age of adoption was about 3 years old, and he followed them until about 58 years old to say, well, how close do these BMIs align? And the interesting thing that he found is monozygotic twins. So these are identical twins. These identical twins, when they were raised in the same household, their BMI correlated at about 70%. Okay, it's about 70%. When these identical twins were raised in different households, it was essentially the same. Meaning that the environment didn't really matter. So in essence, the take home of the study, and this is where we get this statistic that's used in textbooks and things, is about 70% of all the things that determine your BMI status is genetics. 70%. Now, you could say, well, 30% behavioral factors, and that's true, but 70% is genetics. If you look at The Biggest Loser, if you, I don't think this show airs anymore. At least I haven't seen it for so long. But in its heyday, this show was awesome, right? Where you would take these individuals that they needed to lose 100+ pounds. You put them together in this farm, so to speak, and all that the trainers did was beat the crap out of them, right? They exercised, they had nutritionists, everything was just for weight loss. And they lose lots of weight if you've seen the show. They step on the scale and everybody holds their breath. Are they going to lose weight today? And that kind of thing. And it's great. Well, some researchers said, you know what? I'm going to follow these Biggest Loser contestants for 6 years to see what's going on with their metabolism. And so they did that. And some things that they found were interesting. And I'm tying this to genetics on why, and then segueing into how we got to where we are with these medications. So what they found is, one, at the end of the show, they lost lots of weight. Now, 6 years later, most of the weight returned. Now, not everybody gained all the weight back. Some people gained more weight than they lost. Some participants were able to keep some of it off. On average, though, almost all the weight was regained. But they looked at their metabolism, their resting metabolism. 6 years later, their resting metabolism was reduced by about 800 calories. Those individuals, and there was about 2 of them that seemed to be able to keep that weight off. So those people who were more successful, their metabolism was reduced by about 1,600 calories a day. Note what I just said. Those individuals who were more successful now we're talking keeping lots of weight off, over 100 pounds. 6 years later, their metabolism was reduced by about 1,500 to 1,600 calories a day. I don't know if you count your calories, and I don't. I went through a period of my life where I did, but I kind of think in hell that's what they're going to make you do, count calories on a stair stepper, so I don't want to do that. But I went through a period of my life where I counted every calorie I put in my mouth. 1,500 calories, especially if you're on a caloric deficit, you're dieting, that's for a lot of people how much food they eat in a whole day. What that means is those people who kept weight off had this crazy ability to overcome genetics to where they were able to do it, because their body says, genetically it says, hey, you should weigh more. They were able to overcome it. The average dieter cannot do that. That's the problem with dieting. The average dieter, and we're going to go into the genetics on why it's so difficult later, into the details, but that's why these medications have been brought forth to say maybe we can give a medication to help. Well, pre-GLP-1s, that's the Ozempic, Semaglutide, these medications have not been effective at all. Let me just hit 2 or 3 of them. Maybe you've heard of them. Orlistat. I think you can get over-the-counter called Ally. Xenical, I believe, is the medical term for it. But Orlistat, it was one of the first FDA-approved weight loss medications. It's a fat blocker, relatively safe, and that's why people used it. That's why you can get over the counter. Average weight loss over a year might be 7 pounds on Orlistat. The problem is it blocks the ability to break down fat. So it inhibits some of their lipase enzymes. It stops the ability of those enzymes to work, and so you can't break down fat. But just think this through. If you're not breaking down fat, where is it going to go? There's horror stories of people out on a date or I don't know, different situations where they're eating kind of a high-fat meal and they're taking Orlistat, and since you can't break it down, they end up the fat exits the body. The only way that it can do that. And there's spotty, oily stool. And so that's kind of the problem with Orlistat. But it doesn't produce that much weight loss anyways. Then we go to other FDA-approved drugs. Bupropion, naltrexone was one that caught a lot of craze when it first came out. And it conferred minimal to modest weight loss. The problem is, and this, outside of Orlistat kind of safe besides the oily, spotty stool. But the other ones, the problem is they all carry big side effects. Bupropion, naltrexone has a black box warning. That's the strictest warning from the FDA for its possible contribution to promoting suicidal thoughts. So you're taking people who may not feel good about themselves already. You're giving them a drug that promotes suicidal thoughts. I don't know how that makes sense at all. So that's not been that effective. And I'm not going to go through all the FDA-approved drugs. Fen-phen People my mother's age, maybe 75-ish around there, probably very familiar with fen-phen. It's fenfluramine and phentermine. It's the combination of those two drugs. And doctors, there was one study came out and showed that, yes, people lost a lot of weight. So the FDA said, all right, we're going to prove it based off of a single study. No long-term follow-up, nothing like that. They approved it. And what they found out, it was increasing risk of pulmonary hypertension and cardiac valve disease by upwards of, we're talking 800, 900%. It was one at the time, there was obviously lawsuits, one of the biggest settlements that there ever was. And so it was a big deal, not safe. So historically, we have not done well with weight loss medications. Now, the last thing I'm going to note to end this episode, and then we'll go to episode, you can continue on episode 2. I want to talk about this idea of obesity as a disease. I'm saying this for a reason, linking this to this medication. In 2013, the American Medical Association came out and they said, okay, we're gonna say obesity is a disease. 2019, the Royal College of Physicians came out and said, yep, obesity is a disease. The reason they said this is important, though. I pose this question to my students all the time in class. I say, hey guys, let's have a debate and debate this idea of, is obesity a disease? And my students, very sharp. They start looking up the definition of disease. Does it fit in that category? That's not what these world-leading medical organizations did. Now, I'm going to read straight from the Lancet. So they're talking about why the American Medical Association said obesity should be a disease. Instead of trying to determine whether obesity fits specific definitions of disease, the American Medical Association used a utilitarian approach to determine whether the recognition of obesity as a disease would have a positive impact on the individual patient, the healthcare system, and the wider society. No, they said, if we change it to saying it's a disease, would it favorably impact people? The Royal College of Physicians, they said this: the main argument of the Royal College of Physicians and those in favor of this recognition is that unless obesity is defined as a disease, the funding for effective treatment options will be inadequate to stop its increasing prevalence and the health and socioeconomic costs associated with it. So in essence, these world-leading organizations said, we're going to call obesity a disease so we can find better solutions and try to stop obesity. Now, you can agree or disagree whether you think that's right or not. I bring that up in this context because the hope was to push the evolution of, I'm going to say medications, other things, but everyone listening understands the way that our medical system works, to push the evolution of medications. And we've kind of done that with some of these GLP-1s. Please stay tuned to episode 2. Tell your friends that may be interested in this topic to listen, especially if they're taking Semaglutide or Ozempic or Wegovy or any of the other medications. In the next episode, we're going to talk about what these medications are and why they may be beneficial. And then in episode 3, we're going to talk about side effects and costs and things like that. And so please subscribe, leave a review. I would very much appreciate that. Let people that you know, if you have any questions for me, please, I'd love for you to leave that as well. Have a good day.